guys, this is video Well Child section 2, that is growth. Objective number letter A, understand the use of growth charts in assessing and determining patterns of growth. Well, the whole point of the growth chart is to help us assess and determine the pattern of growth. So I grabbed a couple of growth charts here. Let's just pick one and take a look. This is the birth to 2 growth chart. It actually goes birth to 3, but we switch over to the big kid growth chart at 2. It's pink, so this is a girl growth chart. We've got weight here, we've got length here, and then on the back, head circumference and weight for length. We don't really use weight for length anymore. That's considered not really helpful. So weight, length, and head circumference at the top. So you can see the head grows really rapidly at first and then kind of continues to grow more gradually. And babies gain weight really rapidly and height really rapidly at first, and then continue, but the pace alters a bit. Pink for girls, blue for boys. This is a big kid chart, so it goes from 2 to 20, and we've got very same things: weight, height, and body mass index on the back there. Okay. Again, want to make sure you're looking at the appropriate chart and whether it's pink or blue for girls or boys. Okay. Importantly, on the growth chart, kids should follow the shape of the curve. So I'll just pick one and show you here. If you are monitoring the growth of a boy on this blue chart, you want to see them pick a curve and follow along it, okay? You don't want to see them pick a curve and then, you know, they're following along, say, the 50th percentile, which is that heavy black line in the middle, or heavy blue line in the middle. They're following along, then all of a sudden they're starting to drift off this way, or all of a sudden they're starting to drift off this way, okay? We know something's changed that we may need to address. So want to make sure that we're paying very close attention to their growth charts at every visit, even if it's a sick visit that they're coming in for. Want to make sure that we're looking at those growth charts every time. All right. Letter B, explain normal growth patterns in neonates, infants, children, and adolescents. So let's go through weight, height, and head circumference. Remember, what is the time of most rapid growth in kids? Think about it. The Jeopardy music's playing. Birth to 1. Okay, it is not adolescence. Please don't put that on your test. It makes me very frustrated because I've said it 1 gazillion times over the course of your medical training so far. Birth to 1 is the period of time of most rapid growth. So let's look specifically at weight. Now, as a neonate, as a newborn, the first thing babies do is lose weight, right? They've been in the swimming pool for the past 9 months. They're going to pee off all that extra fluid that they've accumulated, and they may lose up to about 10% of their body weight in those first few days. They usually start to regain it and are back to birth weight by 10 to 14 days. Some breastfed babies may take up to 3 weeks to get back to birth weight, but more commonly they're back to birth weight by 10 days to 14 days. Once they start gaining weight in that newborn to 3-month period, they gain about 1 ounce or 30 grams a day. In the 3 to 6 month period, 20 grams a day, and in the 6 to 12 month period, 10 grams a day. And it's that point in time that the parents come in and say, you know, I just don't think he's growing anymore, because they're used to the baby getting an ounce or 30 grams heavier a day, and all of a sudden they're gaining an ounce every 3 days, and the parents don't feel like they're growing as well as they used to, but actually they're appropriately following the shape of the curve. Rehash. Newborn to 3 months, 30 grams. 3 months to 6 months, 20 grams. 6 months to 12 months, 10 grams per day. If you want to look at it by weight, so they're going to double their birth weight by 4 months and triple it by 1 year of age. So if you're 7 pounds even at birth, by 4 months they ought to be 14 pounds. By 1 year they ought to be 21 pounds. Looking at it simply. And somewhere around 7 pounds is a good weight for an average newborn. Between the first year and third year of life, babies gain an average of 7 to 9 grams per day. Again, it's a much slower pace at that point in time. So between 2 years and puberty, babies tend to gain about 2 kilos per year. Now, once they get to puberty, things are going to change. But between 2 years and puberty, 2 kilos per year. Height or linear growth. In the first year of life, babies grow about 25 centimeters. Between year 1 and 4, they grow 10 centimeters per year. Between years 4 and 8, 5 centimeters per year. And then that continues about 5 centimeters per year until they reach puberty and start that growth spurt somewhere, whenever they start puberty. So first year is 25 centimeters. The next first to 4 year is 10 centimeters. 4 to 8 year and thereafter until puberty is 5 centimeters. 25, 5, 10, okay? Making that a bit easier to remember. Head circumference, remember baby's got open sutures in the head. And we got that anterior and posterior fontanelle. Oh yeah, this is clearly going to be my picture for this video. So the head circumference really reflects brain growth. In the newborn to 12-month period, the head grows about 1 centimeter per month, but a lot of that's done in the first 6 months. The first 6 months is when that head really grows. So by 6 months old, they've got this big old baby melon on this teeny little baby body, okay? So that head grows really fast. They're mostly noggin at that age. Brain weight doubles by 4 to 6 months of age and triples by a year. Remember, just like their body weight doubles by 4 months, triples by a year, brain weight does too. And the majority of brain growth is done by 4 years of age. So by 4, they pretty well got an adult noggin on their little 4-year-old body. Okay, so their head is a very large portion. Their head is a very large portion of their body. And that is important to know, particularly if you're looking at surface area for burns or other injuries. Okay, distinguish variants of normal growth in healthy children. Oh, one other thing to mention about growth charts is that there are special growth charts for special needs. WHO has a growth chart that's more applicable to less industrialized communities. There are special charts for breastfed babies, babies with Down syndrome, Williams syndrome, Turner syndrome, or achondroplasia. So if you have an infant with a specific syndrome, it's worth checking to see if there is a growth chart that you should be looking at specific to their condition. Okay, normal variants of growth in healthy children. Let's compare constitutional delay and familial short stature. Why don't you pause the video here and see if you can do that on your own. And I will grab my notes that I've taken here so we can go back through those together. So remember, familial short stature is just like it sounds. Everybody in the family's short. Okay, it runs in the family. So parent stature, both parents are going to be small, or one parent is small. Puberty for a child with familial short stature will happen around the time that the parent's puberty happened. So sort of go back a little bit. So parents' puberty happened at the normal time. Apologize for that. So the parents, one or both are small, but they had puberty at the normal time, okay? And kids' puberty usually happens about the same time the parents' puberty happened, within 2 years. But that doesn't have anything to do with this. These kids are born normal length or even a little smaller than the average baby. They grow normally between birth and puberty. They have a normal bone age. They have normal timing of puberty onset, but their growth during puberty can be slightly low to low end of normal, and they just reach a short adult height. They are petite, just like their parents, okay? So familial short stature, their pace of growth is normal until puberty. Sometimes in puberty it may be a little slower than their peers, and they're just short. Their parents, one or both, is short. Puberty happens at the normal time. Their growth plates, their growth plates, their bone age, their pubertal status, all of those things are normal, okay? Nothing abnormal. Constitutional delay, parents are of normal height, but one or both may have had puberty a bit later. You know, they may say something like, I was a late bloomer. These kids are often born at a normal length. They may grow slowly from mid-infancy to mid-childhood, as well as from 2 to puberty. Their bone age is delayed, and their puberty onset is often delayed as well. During pubertal growth, their growth spurt is delayed and the rate may be slightly diminished. So basically everything's just put off a little bit. Their growth plates stay open longer. They have a delay till the onset of puberty, so they get longer to grow. And then once puberty happens, they usually catch up and have a normal adult height. So familial short stature, they grow at a normal pace, but they're going to be short because other people in their family are short. But puberty happens at a normal time and their bones are not delayed. Constitutional delay, everybody's normal height, including the kid at the end of this, but puberty's delayed, bone age is delayed, but they'll get there eventually. They catch up to their peers. It's kind of like a little pause, taking a little chill before they go through puberty. Okay, constitutional delay, taking a little chill before puberty. All right. Identify abnormal patterns of growth and recall the differential diagnosis for these. So failure to thrive is when you are expending or burning more calories than you're taking in. So calories out are greater than calories in. And there can be 3 main categories of causes for this. Either you're not eating enough, you're not absorbing enough of what you're eating, or you're burning off more calories than what you're eating. This manifests on the growth chart as crossing 2 percentile lines are kind of falling off the growth chart. Making sure now that you're correcting for gestational age and making sure that you're looking at the appropriate growth chart. Remember, Down syndrome, achondroplasia, they're going to have their own growth charts. You want to make sure correcting for prematurity, making sure you're looking at the right growth chart. Crossing more than 2 percentile lines, falling off the growth chart less than third for BMI, we're going to be getting concerned. Let's talk about the differential diagnosis. Why don't you pause it here and make yourself a differential diagnosis. Okay, I'll give you mine now. So decreased intake could be related to some sort of feeding difficulty. So the baby may not be latching or feeding at the breast well, may have cleft lip or palate. They may be living in poverty and may not have any food at home. And sometimes that results in improper formula mixing. So they're putting a lot of extra water in there to try to make that formula last longer. Or maybe they're just a bit impaired and not able to mix the formula properly. Non-accidental trauma, child abuse. Caregiver depression is associated with poor feeding in babies, postpartum depression. We want to make sure that we're screening and evaluating for that. And reflux disease can cause decreased intake. Decreased absorption, that would be a malabsorption syndrome, a protein losing enteropathy. Inborn errors of metabolism can cause this, along with anatomic GI malformations. And my new favorite word, FPIES. Food protein induced enterocolitis syndrome is a malabsorption. Kind of like a food allergy, but go read about FPIES because I like saying it. It makes me want to eat a fried pie. FPIES. Got to plug my computer in here. Bear with me. Saying my battery's low. I thought I had it plugged in. Okay, now we're cooking. Increased expenditure, those are going to be the babies that have to work hard to keep their everyday going. So cystic fibrosis, congenital heart disease, recurrent infection, and those babies with our children with a malignancy, a type of cancer. Those babies are going to have increased caloric demand because they're just burning a ton of calories to keep their little bodies going. Identify overweight and obesity. Well, that's when calories in are greater than calories out. And controlling what goes in the pie hole is typically the problem. Everybody's going to tell you their kid is active, except for the disgruntled parents of teenagers who play too many video games. All kids are active. They're running around the neighborhood. They're playing with their friends. But if they come home and eat 3 Ho-Hos and 4 Twinkies, then they are going to be obese. Calories in is typically the problem in this situation. And even if there is a metabolic disturbance or a disturbance of the endocrine system that causes kids to be very hungry, to put on more weight, we still aren't going to get any better if we don't restrict those calories. So overweight and obese are not based on a set number as they are in the adult population. You know, a BMI of, 40 is going to be obese. I know 40 is an extreme number, but you get the picture. It's not a set number. It's going to be a percentile, okay? Because the BMI is going to change relative to the age. So for instance, in a 5-year-old, 50th percentile BMI is going to be like 15.5. Okay, that's going to be like malnourished in an adult. But if you look at a 16-year-old, 50th percentile BMI is going to be 21. So, it varies based on age. We want to make sure that we're looking at this chart and we're using our percentile scores. So overweight is considered to be 85th to 94th percentile, and 95th or greater is considered to be obese percentile-wise. Want to make sure you're looking at that chart to figure out overweight and obesity. All right, this concludes our growth section.